All right, welcome everyone to the Epidemiology 2 section of the World Malaria Day breakout sessions. We're going to go ahead and get started with our presentations. As a quick reminder, there are 5 minutes total, and we are anticipating about 3 minutes for the presenter to present their slide, and then 2 minutes of Q&A. For the Q&A, if you are in this room, you are welcome to unmute your microphone and ask the question verbally, or you can enter your question in the chat. I will try my best to monitor the chat, but knowing I'm seeing chats coming from all rooms, so it might be hard to differentiate which question is going to where. So, but I'll do my best. So I'm gonna go ahead and switch the slides now. And Tamaki, you will be our first presenter. Oops. All right, so our first presenter is Tamaki Kobayashi from Johns Hopkins University. Tamaki, we'll start your timer now.
Wonderful. Thank you so much, Jessica. So thanks for the quick introduction by Jessica. My name is Tamaki Kobayashi, and I work at the Malaria Research Institute at the Johns Hopkins University. And thank you so much for staying, and I'm super excited about sharing our work as well as listening to other people's work too. And today we wanted to share our work of malaria epidemiology, especially and its use of it, especially in the area of declining transmission intensity. So first, I want to bring your focus to the middle of this presentation, which is the map in the middle, Zambia Malaria Indicator Survey 2018. And where I indicated in a circle, that's the southern province, Zambia, where we do a lot of work, but it says 0. So meaning that when they conducted Malaria Indicator Survey in 2018, there was no microscopy positive malaria parasite found among under 5 years old population they screened. But when they found no malaria parasite among 5 years old population that they screened, does that mean that there's no malaria in this area? Clearly it's not, but what does it actually mean? And how can we get better understanding of it using the seroepidemiology? That's what I would like to cover in this presentation. So the first, I would like to draw your attention to the one on the left, protein microarray. We used a protein microarray with a panel of 500 Plasmodium falciparum antigen that was provided by Phil Faulkner and his team from UC Irvine. And from this data, what we found was under 5 years old from this area, the samples were collected in 2015. They basically were comparable to US naive population. They really didn't have any, sufficient IgG level to malaria parasite. So for those individuals who were born in this area after 2010, because the samples are collected in 2015, they really had very little exposure to malaria parasite. And what does that mean to the community? Now I want to shift your focus to upper right, whole parasite lysate EIA. So this is our in-house tool to look at the age-specific malaria seroepidemiology, and the specific IgG level to malaria parasite declined from 2009 to 2018. And not only the slope of the younger age population, which corresponds to force of transmission in this area, the overall seropositivity among older population declined, meaning that older population has lost accumulated immune response to malaria parasite, and that would indicate more older people may present to health centers with symptoms. Lastly, I want to conclude this presentation with the bottom right multiplex speed assay, which we are working in collaboration with Chris Drakely and Kevin Tete from London School of Hygiene and Tropical Medicine. We are this is actually something that we recently started, but basically we are trying to correlate key malaria variables and with the level of immunity that are antigen specific with the antigens that are listed here. And we would like to, we're super excited about this study, and we hope that this has some potential use, especially to understand more individual level immunity in the area of declined malaria transmission. Yeah.
Thank you, Tamaki. We have just about 30 seconds for a question. If anybody has a question, feel free to jump in. I just had a quick question, knowing that I know this area fairly well. But because we've seen this like decline in seroprevalence for malaria antigens, are we seeing an increase in severe malaria amongst the youngest ages in this area?
So not the severe malaria. I think it's a little bit more complicated because I know that we had some pediatric admission that ended up, unfortunately, we lost the patient, but I think it was a complication with malaria and something else. So I think as long as those people who are reaching to the clinic, especially the hospital, they are getting a care that will not lead to a fatal outcome. But I think the bigger issue, or potentially bigger issue, is that I think we're seeing more individuals who are older, but they're showing malaria specific signs and symptoms, and we know that the immunity of older population in this area has gone down, but the malaria is becoming like, it's not just limited to under 5, but I think there is a still strong idea that the focus population is younger. Of course, they are more vulnerable along with pregnant women, but the onset of malaria signs and symptoms are sort of complex matter between parasite challenge and host immune response. So I think that needs to be understood.
Okay. Thank you. Thank you very much, Tamaki. If anybody else has questions, you can enter them into the chat. We will need to move on to our next presenter. Our next presenter also comes from Johns Hopkins University and is Collen Saudu. Collen, go ahead and unmute your mic.
Good afternoon, everyone. Can you hear me?
Yes, we can.
Okay. My name is Collen Saudu. I'm a founder of Young Leaders Organizations, and I'm a student in Johns Hopkins. My study area is to get the effectiveness of prevention and control methods applied towards achieving elimination of malaria in Botswana. So Botswana is located in Southern Africa, and government of Botswana, as well as the Ministry of Health, adopted 6 strategies to eliminate malaria, which one of them is program management and coordination, then second, vector control and personal protection, case management and chemoprophylaxis, information, education, communication advocacy, including community mobilizations. Then the 5th is surveillance and operational research. Then lastly, it's epidemic preparedness, response, and all of this. So in this study, we are trying to look at the interventions that government is using to prevent and control malaria. So we collected a retrospective data from government, the rainfall from meteorology, then the number of cases of malaria from the Ministry of Health, then the data on indoor and residual spray, the long-lasting insecticide nest, then we collected data on larviciding. So we're trying to compare this data because malaria happens more like in a system. There are factors competing in a system. So we're trying to eliminate certain factors in a system. So what we find out in this study is that the malaria incidence and rainfall are directly proportional. When you look at the amount of income that government is investing in terms of indoor residual spray and long-lasting insecticide net, there is no any correlation whether they distribute mosquito nets or whether they spray. The data is not telling us that. So this is a very interesting study. So for us to relook at some of our control methods that we're using and be able to go back and find out if the time when these methods were introduced were effective, where are we missing it? Is it in terms of implementations or is it an issue of an efficacy? Now, in 2017, the heavy rainfalls gave us a huge setback after we failed to eliminate malaria in 2015. So there's an important study for the government of Botswana, and it can be able also to affect policy. So an improved forecasting can be used to predict malaria in Botswana. So thank you very much.
Thank you, Collen. Does anybody have any questions for Collen? Feel free to unmute your microphone or enter any questions in the chat.
So, hi, Collen. So I have a quick question about, you said that in 2000, there was a heavy rain that put your malaria reduction goal like set back. That's like about 5-6 years ago, right? Has that brought back to what was initially, or is it still dragging at this state?
Well, Botswana experienced heavy rainfalls about 2 weeks ago, and the number of cases have been growing now. So this data is just because we collected data from 2000 to 2018. So it's retrospective data from our government. Then once the number of cases have gone high, they will remain high for some time because of the parasite in the blood. Now, there's a question whether the success story of 2008, when the number of cases are reduced from about 4.2% to about 1.1, almost less than 1%, was it due to the control methods or was it due to the drying weather? Now, in this study, we are able to conclude that the success story of 2008 in Botswana was basically because of the drying weather, not because of the control methods applied.
Okay, thank you.
Sheila, I see you have your hand up if you have a quick question.
Yes. Yeah, thank you very much. Thank you very much, Collen. Last year, there were a number of deaths due to malaria in areas where normally there is no malaria. So what do you attribute to that, and how do we use this to prevent that in the future? For example, the district, there were 6 deaths from malaria.
Yes, especially the southeastern part of Botswana. Even in 2017, the number of cases were recorded. What is happening in Botswana? There were some among researchers which we have always said that, based on our control methods, a heavy rainfall can give us a huge challenge, because with a heavy rainfalls, we end up experiencing a number of cases in certain areas. Because during a heavy rainfall, we end up experiencing floods, and we end up also having lower and higher areas channeling, and mosquitoes are able to breed and develop in those areas. So there's a huge migration in terms of the mosquitoes.
Thank you.
Thank you, Collen. We have to move on to the next presentation. Our next presentation is coming from Tassew Tefera Shenkutie from Deborah University in Ethiopia. Tassew, you can go ahead and unmute your microphone and begin.
Thank you very much for this invitation for this nice symposium on malaria, World Malaria Symposium. Just I am Tassew from Deborah University in Ethiopia. Now I'm going to present on prevalence of G6PD deficiency and distribution of its genetic variants among malaria suspected patients in Metehara Health Centers. Now Metehara in Ethiopia, one of the malaria endemic areas, and there is a sugar factory in Metehara just around the town, which there is cultivation of sugar canes, which treats the breeding of Anopheles or the mosquito, which transmits the disease. So we do the studies in Metehara Health Centers for this G6PD deficiency. As you know, G6PD is one of the metabolic enzymes which have a vital role for the pentose phosphates pathway, and along this normal metabolic activities, this G6PD just produces or just reduces the NAD into NADH, and finally it results for the production of reduced glutathione that removes the oxidative oxygen radical, which is toxic for red blood cells. So we measure these G6PD enzymes just to test for the populations for the deficiency of these enzymes. Finally, which impacts for the primaquine treatments when the patients are deficient for these enzymes, while we treat with them with primaquine, there will be acute hemolytic anemia. So for that, we measured G6PD deficiency in a cross-sectional study design. Then finally, just the results of our study is about the prevalence of these deficiencies was 3.6%. And we do the both the phenotypic and genotypic analysis of these enzymes. So phenotypically, it was the activity of G6PD enzyme was the deficient proportion was 3.6%, and genotypically these various variants were identified, about 3 G6PD variants, G267 plus 119T variants, and G376 T variants, and the other is chromosome X 1535454443 variants were identified here. So these are the results of this our study. Finally, from this we conclude that just from phenotypic measurement of these G6PD enzymes, so the patient should be treated in the study site, or in general in the populations should be treated in a careful follow-up for hemolysis adverse effects of the primaquine treatments. And from this small-scale study incites us just for the requirements of a wide-scale study with just throughout the country in a large sample size, and also with other special techniques like spectrophotometrics needs to be analyzed with these methods. That's our recommendations, just as this small-scale study inside these results. So this is all about our study. Thank you very much.
Thank you, Tassew. We are at the 5-minute mark, so unfortunately I can't open up for the questions right now, but if you do have a question, you can enter it into the chat. I just want to make sure everyone is seeing the correct slide, that you saw Tassew's slide right now, and I'm changing it right now to the next one. If somebody can confirm. Okay, great, thank you. Okay, so our next speaker is Margaux Sadoine from Université de Montréal in Canada. Margaux, please go ahead and start.
Hi, thanks. So my name is Margaux Sadoine. I'm a PhD candidate in public health at Montreal University. And today I want to present this analysis, which examine the influence of environment on malaria in presence or absence of vector control interventions. So for this study, we use weekly laboratory malaria confirmed cases from 6 health facilities around Uganda that are part of the malaria surveillance program. The intervention we analyzed included long-lasting insecticidal nets and indoor residual spraying. So the Ugandan population received nets during 2 universal distribution campaigns, and IRS has been carried out in high transmission areas since 2006. The environmental driver we analyzed included enhanced vegetation index, rainfall, temperature, and humidity, all extracted at a daily scale from remote sensing sources and average over 1 to 4 months, except for rainfall, which were cumulative. We compared this period between them and kept the model with the smallest AAC. The analysis was performed with general linear models based on negative binomial distribution and cluster standard errors. The weekly visits at the clinic were the offset of the model, and we also included the regional monthly household income as a covariate. So from the descriptive table, you can see that for the period 2010 to 2018, there was an average of 73.3 weekly cases across the 6 facilities and 425 weekly visits. And the average income of the 6 region was 309,000 Ugandan shilling, which represents around $87 US. So in the figure 1, you have the representation of the adjusted prediction of malaria weekly counts for each environmental variable. The pink curve represents the effect of the variables when the population doesn't own the mosquito nets, and in blue when the population owns the mosquito nets. And all these effects are presented in the absence of indoor residual spraying. Unfortunately, I couldn't present all the results today. But from the figure 1, you can see that the nets alone have a protective effect. And precisely the influence of environmental variable was reduced by 29% with the nets alone compared to no nets, by 61% with the spraying compared to no spraying, and by 72.5% with both interventions. So there is a greater effect of the spraying compared to nets, but the combination of the 2 interventions gives additional protective benefits against the effect of environment. These are preliminary results, and we will explore interaction between environmental variables and the intervention in the future to see if there is a protective or non-protective effect of the intervention depending on the level of the environmental variables. Thanks for listening.
Thank you very much, Margaux. We do have a minute and a half for questions. I think Tamari, go ahead.
Yeah, thank you so much for this presentation. I remember from the earlier presentation that the Uganda ICEMR did, and there was quite a significant difference between the different IRS that was done. If I remember correctly, like in some areas when the IRS was done, there was an increase, and the area where there was no IRS, there was decrease. And I think there are a lot of like environmental factors into that. In your analysis, are you looking at the impact of IRS or LLIN distribution, like average of the all years, or are you actually maybe this is something to do with the way you're analyzing the data? And I'm so sorry for not having the good understanding of the biostatistics, but I feel like, how did you handle the change over the time in your analysis?
For the mosquito nets, I have considered I've started how can I say that? I consider a 2 years survival of the nets, because we know that it's supposed to last 4 years, the long-lasting insect nets, but we know that with the use, the nets gets holes or and not use. So I consider 2 years for the nets. And for the spraying, it was several continuous round, and I ended up the period with the residual efficacy, the supposed residual efficacy.
Okay, thank you very much. I know it's difficult to explain some of these complex analyses in such a short amount of time, but good job trying. We do have to move on to the next presentation, unfortunately, but feel free to add any additional questions in the chat. Our next presentation comes from Chiziba from Northwestern University. Chilochibi, go ahead and unmute and you can begin.
Thank you. Hello, everyone. So the motivation for our study is drawn from the fact that in 2018, as some of you may know, that 23% of children under the age of 5 tested positive for malaria in Nigeria. That's according to the DHS. And as you may know, the under 5 age is one of the most malaria-affected age group, and they contributed to the overall malaria in many countries, including Nigeria. So, and Nigeria is still the world's most malaria-burdened country. And however, malaria is heterogeneous over fine scales in some urban areas, as seen in the map on the left. And there we can see the map showing the heterogeneity in both urban and rural areas. Yeah, so this diversity in malaria prevalence is also seen in the urban map, where we see high prevalence, which could be due to a number of factors that surround children living in those different areas. One likely factor contributing to this heterogeneity is livelihood practices that promote mosquito breeding and exposes these children to vector biting. Yeah, one of those livelihood instances that I've mentioned is urban farming. So farming practices as a research sites is known to promote malaria vector breeding if not managed properly. Yeah, so from our study, we used the demographic health survey for 2018 for Nigeria and some geospatial data to evaluate the association between parental occupation and malaria infection status among children. So we conducted descriptive analysis and constructed multivariate logistic regression models. Yeah, so the reason why we chose a binary logistic regression was because we want to estimate the probabilities of a child testing positive for malaria. And as you can see in the middle, our variable of interest, just from the descriptive analysis, shows that male parents in agriculture had greater proportion of children testing positive in urban areas. And also, because if we use logistic regression, we can identify variables that are potential explanatory variables. So I've just taken you back to the methodology part. That's the reason why we did that. And when it comes to the results, we see that children with parents working in agriculture had higher odds of testing positive for malaria. And also, as we can see the probability plots, we see that children who had parents who work in agriculture had higher probability of testing positive compared to those with non-agricultural workers. And with that, our findings seem to suggest that children residing with individuals in agricultural occupations in urban areas may be more severely affected by malaria. Therefore, there's basis to suggest that the need for them to be prioritized during interventions in urban areas. And in addition to that, the data also suggests that there's need to further understand how agriculture practices contribute to malaria burden in urban areas to better inform the designs for control programs. Thank you.
Thank you very much. This is very interesting, especially the proportion or the people that work in agriculture that live in urban areas. I'm assuming that these urban is defined in the DHS survey, and it's a respondent-driven question. Is that correct?
Indeed, so we got the definition from the DHS itself, which is in line with the administrative definition of urban areas in the country, Nigeria.
Okay. And does anybody else have a question for Chilochibi? Kaisen asks in the chat, did you control for the type of work? I guess the type of agriculture, I'm not sure if it includes further details on the type of agriculture work that they do.
At this point, we did not do that, but that's in the next plans that we have to do. So we are also looking into that, though this presentation does not point that out.
Great. Okay, that brings us right to the 5-minute mark. Thank you very much, Chilochibi. That was great. We are going to have to move on to our next presentation. Our next presentation comes from Kallista Chan from the London School of Hygiene and Tropical Medicine in the UK. Kallista, you can go ahead and start.
Yep. Hi, everybody. Good evening from London, as you can hear from the ambulances in the background. So I'm from the London School of Hygiene and Tropical Medicine, and I'm a PhD candidate there looking at the relationship between rice and malaria. So it's pretty well known that rice fields in Africa are major breeding sites for malaria vectors. But surprisingly, when the relationship between rice and malaria was reviewed back in the 1990s, in settings where transmission was more or less intense, malaria was not greater in villages with irrigated rice. And this phenomenon was called the Paddy's paradox. And it helped reassure rice experts in Africa that they are contributing to development and not making the malaria problem worse. Since then, however, there's been a lot of changes in the malaria situation in sub-Saharan Africa. There has been a massive scale up of intervention coverage, and malaria infection prevalence has since halved. So we decided to re-examine this rice-malaria relationship to find out whether nowadays, with lower malaria transmission, malaria risk is greater in rice areas. So we conducted a systematic review and meta-analysis comparing malaria indicators between rice and non-rice communities. And our study confirmed that in rice growing areas, malaria vector density was up to 8-fold higher in rice communities. We also found a significant difference in malaria prevalence pre and post scale-up of interventions, where, as you can see on the bottom right graph, in studies performed before 2003, malaria infection prevalence was not higher in rice communities, as you can see by the blue bars. But in studies performed after 2003, in the lower part of the graph, malaria prevalence was 70% higher in rice communities. This means that previously, when there was little protection against malaria in poor rural communities, and rice communities were better protected because rice farmers could afford bed nets, drugs, and better housing. But then nowadays, non-rice communities also have bed nets, drugs, because of the scale up of interventions. So we can no longer say that rice farming brings greater protection, and instead it could bring greater risk. So thinking about the two players behind this problem, on the one hand, you have the ministries of health planning for the elimination of malaria in sub-Saharan Africa, whereas on the other hand, you have ministries of agriculture looking to expand rice cultivation. So these developmental plans clearly interfere with one another. So how do we tackle this problem? Some people that work in agriculture might say that more bed nets need to be given out to rice communities, but is that really a solution? It definitely isn't a very permanent or a complete one. So how can we integrate the agricultural and health sectors to work on this together? My team and I have been collaborating very closely with international rice research institutes to find methods of growing rice without growing malaria vectors. So basically together, we think that rice experts should know sooner and better than anyone else what effect their recommended production methods have on mosquitoes too, since they're already taking into account of things like rice yield, water consumption, weed production, and sometimes greenhouse gas emissions. So mosquitoes could be another factor to account for, where entomologists would give a lot of technical aid. So the ultimate goal is to find a win-win technical solution that can maintain or improve rice yield whilst reducing malaria vectors. Thank you.
Thank you, Kallista. That was very interesting. We do have about a minute for any questions, if anybody has any. I was wondering, I'm assuming these were all from like clinical cases, but was there any entomological work that really describes the type of vectors and like the number of vectors and how they changed during this pre and post, comparing like rice versus non-rice areas?
Yeah, so we did both entomological and epidemiological indicators. So the entomological indicators showed that Anopheles gambiae SL, which includes Arabiensis and Gambiensis, as well as Kallista, were all increased in rice areas. And this is the main reason why the situation in sub-Saharan Africa, the malaria and rice situation in sub-Saharan Africa is so severe, because these are the most efficient malaria vectors in the world. And these rice fields are very capable of breeding them, proliferating them up to eightfold.
And there's also a question that was posted in the chat. Do you know, this is from Japhet from Malaria Research Trust in Zambia. Do you know if the rice in these studies like is from commercial agriculture or from more subsistence farming?
I think it's a little bit of both, but in general, in sub-Saharan Africa, a lot of the time, rice fields there's not as many commercial rice fields, but more small scale subsistence farming rice farmers, but there are large irrigation schemes that may be organized or looked after by organizations.
Okay, great. Thank you very much. That brings us to the end of this talk, and we have to move on to the next one. Our next presenter is Gabrielle Robbins from MIT here in the US. Gabrielle, go ahead and unmute and we can begin.
Hello, can everyone hear me?
Yes, we can.
Great, I'm gonna keep my video off. I'm in Madagascar and we have bad service right now. But hello everyone, I'm Gabrielle Robbins. I'm a medical anthropologist and a PhD candidate at MIT. I research plant-based medical industries in highland Madagascar and their implications for global and environmental health. So what economies am I talking about here? Artemisia annua has been cultivated in the highlands in this area shaded in gray since 2005 to make artemisinin for ACTs. In 2020, the Madagascar president also rolled out a COVID-19 preventative /treatment that also uses artemisia. This was extremely controversial, not least because the WHO expressly recommends against raw artemisia preparations to avoid spreading resistance. But cultivation throughout the highlands increased and honestly skyrocketed because of this kind of overlap between COVID-19 and anti-malarial economies. And by my estimate, there's now more than 20,000 farmers involved in artemisia cultivation throughout the highlands. So I've been tracking how this industry and pandemic economic conditions, especially inflation, impact raw Artemisia annua consumption for both COVID-19 and malaria symptoms. And what I found from about 100 interviews across 4 different villages around the southern highland city of Schue is that something like 80% of my respondents have relied extensively on Artemisia teas and other raw preparations in these cultivation hotspots, largely outside of formal medical economies. So they were reported using Artemisia for symptoms like fevers, chills, and coughs, and an even higher percentage, something like 90%, report keeping and saving Artemisia that they had grown for their own use or that of their friends or their families. So you have extensive informal use in these areas. In contrast, you have much fewer report access to endpoint pharmaceuticals like ACTs, and most actually report access to endpoint pharmaceuticals for things like children's vaccines rather than malarial infections or adult infections. Meanwhile, I have also tracked inflation impacts. The inflation rate since the pandemic started is something like 6.5%, which means that most families are spending much more proportionally on food and other livelihood goods than they did pre-pandemic, which is further constraining their access to endpoint medicines and treatments. So I see some various implications for this research. you have an extremely high rate of reliance on these homegrown and informal treatments. I think that this is a matter for further sort of research on resistance surveillance and things like that, especially since Artemisia-based agricultural systems are becoming even more widespread throughout the African continent. And going back to the conversation that we were having in the last talk, I think that there's also a justice component here in that these are the communities that are providing the raw materials for ACTs, but still lack access to the endpoint ACTs in the first place. So as we talk about trying to reduce emissions for global health systems and things like that, I think there's a large question about how to better improve domestic production of endpoint pharmaceuticals rather than just raw material production. Happy to take any questions, and thank you very much.
Thank you very much, Gabrielle. That was really interesting. I do have a question from Tamari Kobayashi. Would you consider this sort of end use of Artemisia monotherapy? And is there like evidence of any kind of resistance building in the area of malaria parasites?
So I would call it a monotherapy in some ways. It's everything that I've seen is sort of just straight preparation of raw Artemisia leaves into a tea. There's very little mixing with anything else. I have seen reports about increasing malaria incidence in this part of the highlands. So far, I haven't seen anything about resistance, but it's something that personally, I think there should be much, a lot of tracking going on, especially since, Artemisia cultivation is also widespread throughout Kenya, Tanzania, Uganda, places like Cameroon, Senegal, et cetera, et cetera.
And I just have a quick question. Do you know what proportion of like global supply is provided by Madagascar, and if that has changed drastically during the pandemic because of this diversion to COVID uses?
Sure, it's an open question about proportion of global supply pre-pandemic. I do know that Madagascar was a major supplier of ACT ingredients for companies like Merck. Once the pandemic started and the president sort of retooled the Artemisia industry, global exports stopped, I think for at least 2020, but they have restarted again. And now there's this hybrid COVID-19 domestic therapy economy and global export ACT economy happening in tandem.
Interesting. Okay, great. Thank you very much. We do have to move on to the next presentation. Our next presenter comes from John. Thank you very much. Comes from Johns Hopkins Center for Communication Program, Albert Casella. Albert, you can go ahead and unmute and begin.
Yeah, thanks, Jessica, and hi everyone. It's good to be with you. My name is Albert Casella. I am a researcher at the Center for Communications Program based in the School of Public Health here. I'm happy to be presenting the work of our team of social scientists, and what I'm hoping to do today is infuse a bit of the human factor into a lot of these discussions. So if we're talking about ITN use, for example, people are using those, and there are factors that drive their behavior, their decision to use it or to not. And what this research is it's a systematic review to look at, within low transmission settings, what are those psychosocial factors that drive it. And on the bottom left, you'll see a theoretical model. It's called the ideation model of communication. And this has been tested in multiple health areas, including malaria, to show that someone's knowledge or their attitudes or whether they believe a treatment will work, it influences their decision to take a certain behavior. We wanted to know, what is the state of research on these factors and their relation with these key malaria behaviors in low transmission settings. So we conducted a systematic review. You can see the notes in the methodology column there. 96 studies were retained. And where those focus, you can see in the map on the graphic on the bottom right. What we were interested in is what was being measured, how was it being measured, and what is the relationship between that factor and a behavior. So for example, if someone thought that if they really trusted their health facility and the health facility workers there, were they more likely to take their child to the facility if they had a fever or not? This has implications for practice, of course, but also can help programs target subpopulations and do some strong work there to address those concerns. What we found was that some of these factors, such as knowledge and attitudes, they're very commonly measured, but they're not measured the same way across studies. So it makes it difficult for you to compare one study to the next. We also found that if someone perceived that they were susceptible to malaria, that was associated across the board with an increased likelihood of using an ITN or of taking IPTP or prophylaxis, for example. What we also found is that of these 96 studies, only 19 focused on groups that experience higher risk of exposure to malaria in low transmission settings, because in those transmission settings, exposure tends to focalize, right, based on occupation, for example. What does this mean for practice? It means that one, understanding the local context is critical. You can't take one survey and apply it to another country without intensive stakeholder engagement. Otherwise, you could be missing big factors. Another is at the same time, there is a need to standardize some of these measures. So I think that's something the research community needs to really get settled. What do we mean when we say knowledge? What do we mean when we say attitudes about malaria? And finally, using this data to then target communication, to target programming at specific groups, because one group's attitudes may differ from another group's, and that kind of data-driven approach is really important and something that this evidence suggests will improve malaria elimination and the path toward malaria elimination. Thank you.
Thank you, Albert. Very much appreciated. I think people often underestimate the importance of human behavior change when we're talking about malaria control. We have a question here. Oh, no, that goes to another person. I guess, have you looked at any, in specific areas, how this changes over time, perceptions and uptake of these malaria interventions as malaria burden changes, specifically in areas where it's reduced drastically over the past couple decades? Have you seen like the changes and trends of acceptance over the long term?
Yeah, so let's take IRS for an example, right? In this review, what these studies suggest is that someone's acceptance of IRS has nothing to do with malaria at all. It has to do with whether they trust their government and the health system as a whole, because they need to accept for their house to be sprayed. And if people in the community haven't seen malaria in a long time, often they don't think it's a big deal. They don't perceive it as severe or that they're at risk. So why are they going to move all of their furniture out, get their house sprayed? There's of course rumors all about that. So what we tend to see, and that's that point of focalization. What we tend to see is that some of these environmental interventions, there's a little less acceptability when we're looking in low transmission settings than you would in DRC, for example, which we just did a study in, and acceptance of IRS is very high there, even though there's not really a national program focused on it. So that's just one example. And yeah, this is 96 studies, so it's hard to generalize, but that's usually what we see.
Good, great. Thank you very much. We are at the end of the 5 minutes, so we'll have to move on to our last presentation of the day, but not the least, of course, is Wataru Kagaya from Osaka Metropolitan University in Japan. Wataru, go ahead.
Thank you so much. Thank you for giving me this opportunity to introduce our research concept. So our group monitor malaria epidemiology in the Lake Victoria Basin, Kenya since 2012. This previous surveillance identified 3 major tasks of the malaria control in this area, as shown in the middle in the blue color, namely high and heterogeneous asymptomatic malaria infection, insecticide-resistant mosquitoes, and inappropriate human behaviors. These are also shared with other malaria endemic areas in the tropical Africa, so we consider this area as a good model study site. To tackle these 3 major tasks, we are currently working on the project focusing on the optimal diagnosis and treatment, novel vector control, and enhancing community engagement in the field. These activities will evaluated by the Center for Malaria Elimination set up in the field site Homobe County and also Mount Kenya University. In particular, as a novel vector control, as shown in the right side, we are working on the idea of orchard plus seeding net. Seeding net is literally the net covering the seedling so that it prevents the mosquito entrance from the eave and kill the mosquitoes that rest on the seeding after the blood feeding. This concept is already proven with small-scale field experiments. So now we combine this with orchard plus material, which is treated with pyrethroid plus PBO, and evaluate in the randomized control trial. We believe this helps to protect those who do not use the conventional bed net, or those who does not have conventional bed net, or those who are bitten by early biting mosquitoes in the living room or any other room which doesn't have the bed net. Another major pillar of our field trial, showing in the left side, is that targets inappropriate human behavior. By collaborating with economists, we come up with an incentive scheme to motivate community people for the better practice. The scheme called conditional cash transfer and lottery incentive scheme allow participants to get some incentive if they can prove malaria negative after a certain period. This scheme lead community to maintain better malaria preventive measures and let them experience less malaria prevent situation. We will evaluate the applicability of this scheme as a policy, but at the same time, we will observe how community members may react from low malaria prevalence situation. The ultimate goal of the project is to combine these findings and develop comprehensive malaria control or malaria elimination strategy by the end of the project, which is 2025. Thank you for listening.
Thank you very much, Wataru. That is, I'm very interested to see the results of the sealing net trial or study, because I think some of our sites that we study in Zambia could really benefit from an intervention like that. So I'll be very eager to see the results of that. And I see Tamaki has her hand up. Tamaki, if you have a question, go ahead.
Yeah, thank you so much for this study. Like Jessica said, I'm super excited to find out more about too. So for this sealing net approach, can you do that with more traditional sort of like, how do you call it? Like a straw based roof material? It just because like a sachet roof material, it just because I see a metal roof, but does it matter? Like, does different kind of roof material matter for your this intervention?
I think the answer will be no, because basically we just tie the net to the top of the ceiling and then coming to the down of the wall, I mean the edge of the wall. So, and also the heat will not affect so much about the insecticide. More, the problem is more of the sunlight. So unless it is covered very well, iron or straw may not impact, I guess. But unfortunately, our study site having the predominantly iron sheet only, so we can't compare that different setting. But it's quite interesting point, I think.
We also have a question here from Kaisen Sangana at Malaria Research Trust too. And I think he brings up a really good point is, do you really think that the conditional cash transfer is scalable and sustainable in like a real world setting? Is there other examples from other areas, even outside of malaria, I guess, that have really good examples of how this can be used to improve behavior change?
Yeah, thank you for our question. So this is already tested and proven with the HIV trial. In case of HIV, most of the risk population is so-called risk grabber. So they tend to motivate by lottery incentive scheme very much. So yeah, we want to see the situation in case of malaria, and also the purpose is not only implement this as a policy, but also bring people to the different situation. So by guiding them after finishing this intervention, they have more motivated to maintain that situation. That is another concept of this study.
Yeah, I know that it's been used in other areas of public health, and I just didn't know specific examples, but great. That is wonderful. Thank you very much to all of our presenters. I know it was very quick. We went through them very fast, but there were some really interesting studies and presentations that were given. This marks the end of this session. I believe some other sessions are still going on, so you're welcome to leave this room and join another if you'd like to see other presentations. Otherwise, thank you to all of our presenters today, and thank you to everyone for joining us for World Malaria Day. And these sessions will be posted at some point on the JHMRI website, so you can find them if you'd like to revisit any of them. But thank you again for everyone for joining.